Good morning, everyone. It's Click. Clack is on the road greeting new honors students in Little Rock at a reception. So I am very lucky to be joined in the studio by Professor Trish Starks.
Good morning.
And it happens to be on a day that on our third section, I'm going to be talking about social Darwinism and where it comes from and how it persists. So I am both embarrassed to be doing it in front of a pro, but I have someone to catch me and really make things sing for the third half. We are very fortunate today to be joined by Christina Counts. Dr. Counts finished her PhD at Duke last year. She is currently, and let me read this correctly, at the Center for Demography of Health and Aging at University of Wisconsin-Madison, one of the legendary schools in the social sciences in America. And next year, she will be joining the faculty at the University of Illinois, Urbana-Champaign, in the Department of Sociology. And we are thrilled to have her with us today to speak about health disparities. So let me make you a co-host so that you can share anything that you want to share. And I believe we are ready to begin. Take it away, Dr. Counts, and thank you again for taking your time to join us.
Of course. I'm so happy to be here. Good morning, everyone. I'm going to, let's get my presentation all ready to go, and then I can share my screen. Okay, let's see here. All right, can you all see my slides?
Yes.
Okay. Yes. Slides, no notes. I always have to double check when I'm on my, I'm only on one screen. Usually I have two, so I can double check. But thank you so much again for inviting me to come and talk about health inequalities over the life course. As you mentioned, I'm Christina Counts. You can just kind of call me Christina. I'm not, I guess, quite a professor yet. I'm a postdoctoral trainee at the Center for Demography of Health and Aging at UW-Madison. And then I'll be starting as a sociology professor. So health inequalities is really near and dear to my heart and what I study as a researcher. A lot of what I'll be talking about today is kind of on the physical health inequalities, but actually a lot of my training is in looking at mental health inequalities. So I'll touch a little bit on that today, but mostly what I do is I think about these things from a life course perspective. And that's really what we're going to dive into today. And I know I've been told to keep my eye on the chat, so feel free to post questions in the chat as we're going along. It's great that I can kind of see everybody. I wasn't sure if I'd be able to see all the students, so I'm excited about that. Okay. So just to give a little bit of an overview for today's agenda, I had you all read two articles. One was on social conditions as fundamental causes of disease, and the other one was on cumulative inequality theory. So after we kind of review social conditions as fundamental causes, we're going to talk a little bit about extending this theory to think about other social conditions besides socioeconomic status. And then we're going to dive into the life course stuff, looking at life course models of accumulation, talking briefly about the role of psychosocial resources, and then finally ending our talk talking about selective mortality and how important it is to think about selective mortality when we are discussing health disparities. Okay, so again, to start off our discussion, I've been teaching now for a couple years, and I know that we don't always read everything perfectly. Sometimes we skim, so I think it's always good to kind of recap some of the main points from the reading. So I had you all read Social Conditions as Fundamental Causes by Lincoln Phelan, and essentially what this original theory, this really formative theory in the sociology of health, states is that there are persistent health inequalities based on socioeconomic status, with those of lower SES having worse health and usually dying sooner than those of higher SES. And they argue that SES is a fundamental cause of disease because it fulfills these four main tenets, and these are going to be really important for our talk today. So the first is that a social condition is a fundamental cause if it influences multiple disease outcomes. So we don't think of something as a fundamental cause if it's only influencing one disease. We want to think about it as influencing a whole set of disease outcomes ranging from mental health to cardiovascular disease to diabetes, cancer, etc. The second is that it affects diseases through multiple mechanisms. So there's not just one pathway by which this social conditioning influences health inequalities. There are several pathways. The third is that it involves access to resources, and I'm actually going to expand this just a little bit to say access to resources and exposure to risks. So those who are advantaged are going to have more resources and less risks. Those that are disadvantaged are going to have less resources and more risks. And finally, that this association between these fundamental causes and health is reproduced over time. So this is not a contemporary phenomenon. This is something that as we look back, decades ago, we see these health inequalities and we see them today. And unless we establish good interventions, we will continue to see them. So as I mentioned, your paper, there we go, Lincoln Phelan focused in on socioeconomic status, but since their kind of original theory, there have been several follow-up articles that consider other dimensions of social life that may operate as fundamental causes of disease. For example, one that has kind of received a lot of attention recently is racism as a fundamental cause. So there are several articles that kind of use different verbiage for this, but racism, racial capitalism, racial residential segregation, which essentially suggests that systemic racism operates to produce health disparities wherein white folks have better health outcomes than people of color. And I want to be really clear here that this is racism, not race, as a fundamental cause of disease. So it is the system of racism that privileges white folks while disadvantaging people of color that leads to these racial health disparities we see over time. Gender has also been considered, and again, not really gender, but more of this macro system of gender inequality and sexism that leads to health differences between men and women, leading generally to men having better health or less chronic conditions than women, which we're going to get to in a second. And then finally, some researchers have even argued that stigma, which is essentially this process of othering other identities or putting some identities down while privileging others, is a fundamental cause. And this has been tied into some research that has highlighted sort of the stigmatization of sexuality, of being overweight, of disabilities, all of these things, the stigmatizing process as a way of producing health inequalities. And today I'm going to focus on specifically sort of class, race, and gender as sort of health inequalities across class, race, and gender, because these are sort of the main three that sociologists have historically looked at. But I do want to mention that this is not an exhaustive list at all of health inequalities. And actually there's been a sort of new focus on health inequalities across sexuality, and some researchers have also expanded looking at gender and sexism to consider beyond just the binary gender, to consider the entire gender spectrum and health inequalities across folks who don't identify as just male and female. So I wanted to mention that. So even though we're focusing on these three, this is not an exhaustive list. And then secondly, before we start, I also have to say as a sociologist that these identities intersect and interact to produce health disparities. So I'm going to be talking a lot about these sort of separately, but in the social world, we all carry numerous identities that work to advantage and disadvantage us across different sort of spectrums of social inequality. So even though we'll be talking about these separately, we can also think about these, how they combine to influence health inequalities. So the way that I'm going to kind of go through this today, try to extend this theory to think about racism and gender structure and sexism, is to go through our 4 tenets of fundamental causes of disease and see kind of how they map onto these other social conditions to produce health inequalities. So that first tenet, if you remember, was that social conditions are going to influence multiple disease outcomes if they are fundamental causes. So you saw from your reading that, this is absolutely true for socioeconomic status, with those of lower SES, lower income, lower education, generally having greater morbidity, which essentially just means being sicker across the life course, and earlier mortality than those of higher SES. If you've kind of been focusing it all on the news a bit, this is again becoming more popular in mainstream media, but we also have a lot of racial health disparities across a host of different disease outcomes. So research has shown that Black Americans have much higher rates of chronic diseases compared to white Americans. Research has also shown that white and Asian mothers experience the lowest rates of infant mortality, with Black and Hispanic mothers experiencing the highest rates of infant mortality. And more recently, we have seen racial disparities in COVID-19 outcomes, with the Black and Hispanic populations representing a larger share of COVID-19 cases, and actually as well as COVID-19 deaths relative to their share in the population. So we do in fact see from this, long line of research, and I could go on, for many, many decades back, that there are racial inequalities across a host of disease outcomes. We also see gender disparities across a host of disease outcomes, with women tending to experience more chronic conditions than men across the life course. Women also have been noted to have greater mental health symptoms than men at essentially every period of the life course, particularly as it relates to mental health symptoms such as depression and anxiety. So women tend to have more depressive symptoms, more anxiety symptoms than men kind of at any point in the life course. I will mention that, interestingly, which you'll see kind of later in the talk, women do live longer than men, which is kind of a caveat to these gender health disparities. But that longer life is usually full of more episodes of disease and chronic conditions. So we have to think about those kind of relatively. Okay, so now let's think about our next two components: affecting diseases through multiple mechanisms and involving access to resources. And I put these two together because I really think that a key mechanism that drives health inequalities are these accesses to resources. These resources can be tangible, such as access to healthcare, or access to literal money to pay to go to the doctor. Urgent care copays are usually like $45. That's pretty expensive. Or resources can be somewhat less tangible. So things like education or social support, social relationships. Here I've listed several mechanisms that can link social conditions to health disparities across class, race, and gender. And I want to take a couple minutes just to give you some examples of these so they're a little bit less abstract. So as I mentioned, several kind of important mechanisms that we think about are things like access to healthcare, health education, meaning sort of the ability to know about ways to promote your health and well-being. One thing that we saw with the COVID-19 pandemic was that health education was not equally distributed across the population. So communities of color, communities of lower socioeconomic status, we're not getting that same level of information about social distancing, about mask wearing that might have led to some disparities early on in the pandemic, using those sort of mitigation strategies. Social relationships and connections, these mechanisms are really important drivers because social connections can help connect people to resources, and they can also be beneficial for us. At the same time, social relationships and connections can be patterned by class, race, and gender, leading to sometimes an unequal burden in the amount that social relationships take from us. So this comes up a lot with gender health disparities. Women are generally expected to take care of other people, expected to sort of give in social relationships, and that can actually be very harmful for women's health. So that sort of gendered expectation of social relationships is a way that women's health is harmed, whereas men don't experience that same burden. Another really important mechanism that's actually becoming, again, sort of increasingly important in the world that we're living in now with COVID-19 is lived environments. So where people live is patterned by their class, race, and gender, their access to healthy foods, their ability to exercise outside, lack of air pollution that makes exercise outside doable, as well as community safety, so feeling safe in your environment. And then finally, something that is really important that I'm sure came up in your racism in medicine discussions earlier this week is patient-provider interactions, which we know are very much shaped by class, race, and gender, with usually people of color and women having a harder time being heard or listened to during patient-provider interactions, which can harm their care, so harm the care that they receive, leading to worse health. So as you can see, there are so many mechanisms here, and I'm sure that you all can think of even more mechanisms that would link these social conditions to different disease outcomes across class, race, and gender. And I also want to say that what's really important to think about when we're considering all of these different mechanisms is that the lack of access to resources or exposure to risky environments or situations all produce stress. So stress in itself is a mechanism that links social conditions to health outcomes through all of these different things that we talked about, right? Not having food access is stressful. Having a discriminatory patient-provider interaction is stressful. And what stress can do to us is that it sort of conditions the body for all of these poor health outcomes across our life. And research is really increasingly showing this as a really important mechanism because it shows how these inequalities get under the skin, again, to sort of impact our physiological symptoms, making us much more vulnerable to diseases and illnesses across our life. So this is something that I think is, again, becoming more and more important for us to think about, that it's not just sort of these risks and resources, but what does that do to folks when they don't have access to these resources? It produces this stress, and that's something we need to think about when we're trying to prevent these health disparities. Okay, so the final aspect of fundamental causes is that these social conditions pattern health inequalities that are reproduced over time. So your paper had a couple examples of socioeconomic health disparities that reproduced over time despite changing diseases or changing mechanisms. So I'm going to just show you just two examples of this across racial health inequalities and across gender health inequalities. So here is I hope you all can see that okay, but here is a map from the CDC that shows life expectancy in years from 1970 to 2007. These lines here are broken up by race and gender, actually. And as I mentioned before, women tend to live longer than men, which is why we have both white females and Black females sort of above white males and Black males. But if we kind of ignore the gender part and we look sort of within gender, you'll notice that for both men and women, Black folks have lower life expectancies than white folks from 1970 all the way to 2007. And actually, if we continued this graph all the way into 2022, we would still see these disparities in life expectancy. And to really drive this home, I want you all to look at here that in 1970, what life expectancy is essentially telling us is the expected number of years somebody born in 1970 is how long we expect them to live. So in 1970, a Black male was expected to only live to age 60. And if we think about that, that's really young, right? You know, I'm sure that like college age, I'm sure you have many parents that are reaching that age or grandparents that are much older than that age. So that's really, really young. What's potentially more upsetting is that if we look at 2007, Black males' life expectancy only went up to about 68, 69. And this life expectancy was the same as white men in 1970. So even though everyone has experienced gains in life expectancy were living longer, Black men, it took all the way to 2007 for them to reach white males' life expectancy. So that really shows you sort of how entrenched these racial health disparities are and how they are really reproduced over time to produce these kind of health disparities that are consistent for decades. And now let's look at gender. So as I mentioned, I'm kind of first and foremost, I guess, a mental health scholar in addition to physical health. So I had to do a mental health plot here for at least a little bit. So as I mentioned, we know that women tend to have higher rates of depression and anxiety than compared to men. And what this map, again, from the CDC shows us is that over, from 2007 to 2016, this gap has been maintained. So this is the prevalence of depression among persons who are age 20 and over. And we see that even though, this is over a 10-year period, a lot has changed. Women are increasingly, the world is becoming more equitable. Women are still experiencing consistently higher levels of depression compared to men, and sort of in a non-negligible amount, right? This is about 10% compared to about 5%, so almost twice as high of prevalence compared to men. And so that we know, I'm sure, mental health has become a really important topic, again, because of the COVID-19 pandemic. And so we know how depression can bleed over to impact so many parts of our life. So mental health inequalities are also really important to think about. So what these examples have shown is that there are persistent health inequalities across class, race, and gender that have existed for a long time despite our changing world, right? Despite any sort of progress that we believe is happening, these health disparities are continuing to exist. So there is reason for us to believe that these are social conditions that are fundamental causes of disease, because again, they fulfill these 4 tenets: that they influence multiple disease outcomes, that they affect diseases through multiple mechanisms, that they involve access to resources and again, exposure to risks, and that the association between cause and health is reproduced over time. Okay, so now thinking about all this, I've kind of primed you to think about health disparities across class, race, and gender, and shown you the importance of documenting these disparities and thinking about how systems of racism and sexism and classism can continuously reproduce these disparities. But a lot of what I've shown you has looked at health disparities research that has focused almost entirely in adulthood. And I love this question I see in the chat about kind of thinking about children and trauma, because that is exactly what we're about to talk about. So we're going to talk about some things back into the life course. So again, a lot of the disparities research has focused on health disparities once individuals reach adulthood. And this is mostly because a lot of health problems that we're focused on, chronic conditions, things like diabetes or type 2 diabetes, heart disease, most college-age students and younger are not experiencing those chronic conditions. So, think all college students, a lot of chronic conditions are not very prevalent amongst younger populations, and they don't usually show up till people are older. And so that's why a lot of our research has focused on folks who are older, so we can actually compare prevalences of these chronic conditions and diseases. But folks live a whole life before we examine them in adulthood. And it may be that experiences in childhood, as teenagers, as young adults, that all accumulate to influence health in older ages. So in other words, these health disparities that we're seeing across class, race, and gender that we observe in adulthood, that we're really focused on sort of intervening in adulthood, may be intimately related to different experiences across the life course as they're related to these different identities. And this is where cumulative inequality, what you all read about today, really comes into play. So cumulative inequality theory essentially asks us to consider one's entire life history when we're thinking about and addressing health disparities. So we don't want to just think about when we measure folks. We don't want to just think about heart disease prevalence at age 50 and just look at 50-year-olds and just think about their lives at age 50. We want to think about all the things that happened before they got to age 50 that might have predisposed them for certain health conditions or might have led to the accumulation of certain risks and resources. So the first two axioms of cumulative inequality theory, which has 5 axioms, if you remember from the reading, you'll notice that these first two look very similar to fundamental causes of disease. So the first axiom essentially saying that social systems generate inequality. And the second is saying that disadvantage increases exposure to risk, while advantage increases exposure to opportunities or resources. So again, this is really very similar to everything that I've talked about so far, that there are these social systems of racism, class, socioeconomic inequality, and sexism that lead to inequality in risks and resources that produce health inequalities down the line. However, cumulative inequality theory now adds this third piece, that life course trajectories are shaped by the accumulation of risk, resources, and human agency. So here I have an example. So I'm a visual learner, so it always helps me to have kind of thinking about these things visually and with examples. So bear with me, let's think about two folks here, X and Z, and we're gonna look at their life course histories, their accumulation of risks and resources, and then I'm gonna tell you about what their health looks like at age 60. Okay, so X here, this top person here, is born to a wealthy family. They attend a prestigious private school because their parents are able to afford to send them to a private school. And at this private school, they have an excellent college career counselor. They have all of the different AP classes that they could even imagine ever taking, let alone just SAT prep tutors, all of that good stuff. So because they have all of these resources at their private school, they are able to get into a top college. And once they're at that top college, because they have, that top college name on their resume, they get into a wonderful medical school, no problem. They complete medical school and they become a doctor. As a doctor, they're constantly around healthcare systems, right? So let's say they're a primary care doctor. They're constantly around healthcare systems. It's really easy for them to just check in on their own health. They have the education to know that, they're getting kind of older and they should be looking at these things. And they actually catch that they have high blood pressure really early due to regular screening. So they're always screening for their blood pressure and they catch, it's looking a little bit high. They go on medication to lower their blood pressure. Now let's look at Z. Z, on the other hand, is born to a lower middle class family. They attend a public school, but unfortunately, this public school is underfunded. So they don't have any access to AP courses and they don't have a college counselor that's available at their school. The college counselor is it's one college counselor for 5 different schools in the district. So even if they get into college, which, they're very bright, so they absolutely can get into college, they haven't taken any AP courses and they haven't had that guidance. So they didn't know to apply to any scholarships. So they're not able to afford college. They still work really hard, right? Z is still incredibly bright. And so they become a contractor, which is a great job. But unfortunately, it's a very demanding job, which means that they can't get time off work. They can't get paid time off work to go into their yearly physical. So they too have high blood pressure, but it's never caught. So they have no idea that they have high blood pressure. It's just kind of existing and they're never going to the doctor. So they're never getting that information and never being put on any type of preventative medicine or preventative care for their high blood pressure. So by age 60, Z has a heart attack, but X does not have a heart attack. So even though both Z and X had high blood pressure, which is kind of a precursor to heart attacks, X never had a heart attack. They, lived a nice, healthy life, whereas Z did have a heart attack. And we know that heart attacks, especially, really at any point in older adulthood, can put you at greater risk for a lot of other complications down the line. And it can really lower your life expectancy as well. So it's really something we want to avoid, which I'm sure you all know. So the question I, think about, and you can even put in the chat some ideas maybe, is what life experience do you think contributed to this eventual heart attack for Z and the no heart attack for X? Do you think it was any specific experience, either in childhood or in adulthood, or do you think it was all of them? Little bits of insults or resources that came into play at these different points during their lives. I see everything combined together. Yes, so we'll get into some ideas about what could it be. I like this little bit of everything. You guys are life course researchers. That's how you're thinking about it. Okay, so I like a snowball effect. Yes, this is awesome. You guys really are life course. You're thinking from a life course perspective. So when we think from a life course perspective, we actually have several different models that help us to think about the influence of early life experiences and adult experiences when thinking about adult health outcomes and adult health disparities. And I didn't have you all read this paper because it's a little bit long and a little bit more technical, but it still is a very helpful paper if you're interested. It's by Crude and colleagues, and they sort of present these different life course models of accumulation of risks and resources. And they name these 4 different sort of pathways by which early life and adulthood can combine to influence adult health. The first is called accumulation of risks. The second and third are chains of risks, but slightly different in how they think about these connections. And then the final is a sensitive period model. Okay, so I'm going to show you, kind of walk through each of these different ways of thinking about early life experiences and adult experiences and adult health outcomes. But before I do that, I just want to again remind you that at every point in the chain, our class, race, and gender is influencing our life experiences and our eventual adult health outcomes. So I'm going to talk about early life and adult health. But remember, at the heart of this are our fundamental causes of disease that are influencing every part of our lives. So the first kind of theorized model is this accumulation of risk model, which essentially states that sort of little bit of everything. So it says that both early life experiences and adulthood experiences are important for predicting adult health outcomes, and that they're going to sort of be additive. So it could be that, not going to a private school or going to an underfunded public school, and it could be not getting time off work. And that's going to add to produce that eventual adult health outcome of high blood pressure and heart attack. Conversely, we can think about this is almost like the snowball effect, where early life influences are going to predict adult experiences, but it's really sort of that proximal adult experience that's important for eventually influencing adult health outcomes. So you can think about this as, not going to an underfunded public school led to not being able to go to college, and that lack of education led to something with adulthood health. So it's not that this early life experience has its own link to adulthood health, it's that it operates through how early life experiences pattern our opportunities in adulthood. And this is called the chains of risk trigger model. Now, the chains of risk additive model is a little bit, more open and says maybe it's a little bit of both. So maybe it is that there is this snowball effect of early life experiences going into adulthood experiences and influencing adult health outcomes. But maybe there is just sort of this important link about something going on in early life that directly influences adult health outcomes. So maybe it's being born to a lower middle class family and having sort of financial stress in early life that sort of has this additional impact on adult health outcomes, in addition to any way that early life SES influences adult SES, for example. And then there's also a fourth theory called the sensitive period model. And this is often linked to this idea that early life is a sensitive period for development. So in early life, we are developing physically, mentally, emotionally, socially, think puberty, right? You're sort of becoming a person during these couple first years of life, 0 to 18 years old. And that any type of trauma or stress during this early life experience is going to be particularly harmful for adult health outcomes. So there might be these other kind of pathways, but the one that we think is especially important is early life experiences. And you might have read a little bit about this in that cumulative inequality theory, but this is something that becomes really important when we think about especially traumas. So thinking about, for instance, the trauma of food insecurity or the trauma of living in an unsafe neighborhood. So those things are incredibly stressful. And that stress during this period of development may have this really, really big impact on our adult health outcomes, no matter if we eventually are able to escape those conditions to better conditions in adulthood. So I present this sensitive period model with a little bit of that caveat of this is potentially the most pessimistic model, thinking that we can't eventually, do things in adulthood that would change how our early life experiences connect to adult health, but it's still important to think about this. And I love this comment too, this mental emotional stress of struggling financially. Absolutely. All of these kind of conditions, not only are we thinking about resources, but always thinking about the stress that comes with them. And intergenerational trauma, that is a wonderful question. And I want you to hold on that question for when we chat after today, because I think that is such an interesting part of research and is becoming really important for folks to think about. So why is this all important? Why is it important for us to think about these different models and to think about, okay, what is this chains of risk? Is it accumulation? Is it chains of risk? Is it sensitive period? Well, adjudicating between these different models, thinking about how social conditions influence early life and adult health, helps us to establish when it is best to have interventions. So let's think back to X and Z here. Let's say that there was somewhere we could intervene on Z's life that would mitigate this accumulation of risk or would mitigate the eventual heart disease and heart attack. Well, maybe we think that it is really just the proximal stuff that matters, right? So maybe we think it's this chains of risk trigger model, that there's no direct connection from early life experiences to adult health outcomes. Really, everything goes through adult experiences, so that's where we want to intervene. Then we could do something like this. So again, Z is going to experience all those early life experiences of being born to a lower middle class family, attending a public school with low funding, not attending college, becoming a contractor. But then instead of not being able to have time off work, we in the United States established labor laws that ensure time off work to get yearly physicals. Or in a lot of places, there are incredible unions that fight for these types of rights of their workers. So maybe Z is part of a union that fights to make sure that contractors get paid time off to go to a yearly physical. So Z is able to go to that yearly physical. They're catch their high blood pressure just like X did. They're put on a blood pressure medication and they do not have a heart attack. So this would be an example of intervening really far down the line, but still potentially getting that benefit of no heart attack for Z. But maybe we think that it's really these early life experiences that matter the most, either through sort of a sensitive period type model, or maybe this accumulation of risk model. And we want to intervene earlier on in the life course. then we would want to focus on right earlier on in this kind of chain of risk that Z is experiencing. So we can't control, what family Z is born into, though we could even go further on and maybe intervene on the parents for socioeconomic equality. But let's just say that Z is born to this family. One thing that the government's public policy is able to do is potentially improve funding for schools across the board. So say that there is some type of public policy intervention that makes sure that all schools have proper funding to offer AP courses to their high schoolers. Z is able to, like I mentioned, Z is incredibly bright. Z's finally able to take those AP courses. Their college, admissions record looks amazing. So they get a scholarship, they're able to attend college. They become a software developer. That's a very flexible position. They work from home. So they're able to go to the doctor whenever they want. They have really flexible work hours, so they're able to get time off to go to that yearly physical, again, catching that high blood pressure due to that yearly screening and leading to no heart attack. So again, these are just two different examples of how intervening at different points of the life course could potentially be helpful. But understanding when to intervene, again, matters on which model we think is best representative of how social conditions influence health inequalities, again, through the social patterning of early life experiences and adulthood experiences. Okay, now before we go on to this next bit, I do want to take a second here, because I think this next question that pops in the chat about how do disparities of socioeconomic resources differ between countries with free healthcare and university education and countries that don't. And that is a wonderful question that again points to this idea of different types of interventions that might be helpful. And actually there's been, a lot of what I've talked about today has been in sort of the United States context, but there has been a lot of work that has looked at socioeconomic status as a fundamental cause of disease across different types of economies in different countries across the world. And what those researchers have found is that in places with more equitable economic structures, either through offering universal health care or higher taxation of rich folks, so more sort of income redistribution, that those countries tend to have less or more narrow health disparities. So those types of large, broad interventions have been shown to be helpful in other countries besides the United States, though obviously the United States hasn't done sort of their own sort of experimenting on this. But when we look to other countries, we do see that that kind of policy is helpful for narrowing some of these disparities. So I think that was a wonderful question to point out. Okay, so I now want us to move on to axiom 4 here, because a lot of what I've talked about so far is pretty upsetting, right? As a medical sociologist, somebody who cares about human beings, like I'm sure you all do, a lot of this is really frustrating, right? You're like, well, there's, I can't control what race I am or what gender, or, you can obviously choose your gender identity, but you can't really choose sort of how people perceive you and how they interact with you in the world. A lot of the times our socioeconomic status, especially in early life, we can't choose, right? We're sort of born into it. So there's a lot of this feeling of, okay, well, aren't these structures just sort of forcing me into this type of life? And what can I do? How can I change this? That's not fair. And this is where axiom 4 comes into play. It's to say that yes, there are all of these, macro structures of inequality at play, but there still is human agency. So our perceptions of our life trajectories can influence our subsequent trajectories. There is an ability for us to show resilience. So a theory that supports this idea of axiom 4 is called the stress process model. Again, I didn't have you all read this today, so this is kind of just an extra tidbit for you all. But essentially, this model was established by Leonard Perlin in the 80s, and it's been since updated by several researchers. But the model suggests that there are several psychosocial resources that may disrupt the link between sort of social inequality and health disparities. And these include things such as social support, mastery, self-esteem, resilience, and a sense of mattering. So a sense of feeling like you matter to the people around you. And so essentially, social conditions as fundamental causes again lead to some disadvantaged groups experiencing more risks and fewer resources. However, folks in these groups may employ these psychosocial resources to lessen the impact of this, exposure to risk and lack of resources, leading to better health outcomes that they would have otherwise. So, I might be experiencing discrimination in the healthcare system, but if I still feel this kind of sense of mastery and self-esteem that, I can still advocate for myself in the healthcare system, maybe that's going to disrupt some of that discriminatory process that would have led to a worse health outcome, and I can be agentic in my healthcare still. So I represent this model with a little bit of a caveat here, because I think that it's really important for us to think about these things, because again, it sort of shows that not everything is set in stone. Like we do have agency over our lives, and that is really important. However, as a social scientist, I do have to mention that this does not mean that this is how we intervene on social inequality. So what this model is saying is that these are ways that folks can be resilient, that they can fight against the system that is placing them in these positions. But we should be able to have systems that don't place people in those positions in the first place. So these social inequality systems, if they didn't exist, folks wouldn't have to be resilient, right? So it's important to think about these things again because of that human agency, and potentially as a way, right, that if we can promote self-esteem or mastery, maybe that is a way to intervene on health inequalities. But as social scientists, we generally want to stop them at the source without having to rely on these, even though they are helpful for folks. Okay, so we're getting kind of towards the end of my chatting. I'm going to have you guys watch a little bit of videos here at the end. But our last little bit for today, for today's lecture, is talking about Axiom 5, which states that cumulative inequality may lead to premature mortality, which skews the appearance of health disparities. So let's talk about this concept of selective mortality as it relates to understanding and discussing health disparities. So far, right, we've talked a lot about health disparities. We've talked about thinking about interventions over the life course, how social inequality produces difference in lived experiences in early life all the way into adulthood, and how that leads to adult health disparities. But the thing that we still have to deal with is this process of selective mortality. So essentially, what cumulative inequality theory states, and what we know as social scientists, is that inequality produces compositional changes in the population, where in population truncation, certain groups dying before others may give the appearance of decreasing inequality. So this is a little bit easier to understand when we think about this visually. Like I said, I'm a visual learner, so it's always helpful for me to think about these kind of concepts with a graph. So we've talked about how racism is a fundamental cause of disease, or can be thought of as a fundamental cause of disease, with Black folks, Black Americans, usually experiencing more diseases and chronic conditions than white Americans. So if we just look at sort of starting off again at age 20, no one really has chronic conditions. But as we get older, we usually kind of accrue more and more chronic conditions. It's just part of the aging process. But you'll notice in this graph that as folks are getting older, Black folks are accruing chronic conditions at a much faster rate than white folks. So again, this is because, thinking of racism as a fundamental cause of disease, all those different mechanisms that may lead to these Black-white differences in the number of chronic conditions across the life course. So we see this kind of dramatic increase for Black Americans, and then we start to see this stagnant and then a drop. So if I just looked at this graph, right, and I didn't think critically about it, I would say, well, it looks like health inequalities just go away by, age 80, right? Everyone just looks the same. And this has actually been something that folks have sometimes concluded, which we're going to get to an example after this. So this is a dangerous conclusion, right? Because this essentially suggests that why care about health disparities, right? If they just go away at age 80 without us doing anything, then why would we care about it, right? Everyone looks the same. So why do we need to do anything? Well, what is actually happening here is that because Black folks are accruing chronic conditions at much faster rates than white folks, Black folks are also going to be dying sooner than white folks. And what that means is that this orange line that sort of shows the average number of chronic conditions across the Black population is that this Black population is slowly sort of losing folks, so that the folks that are left by age 80 are going to be our most healthy population of Black Americans. So you can think about that the Black Americans with the greatest number of chronic conditions are dying and are not reaching age 80. They're likely dying, again, if we think back to life expectancy of Black males being around 68, so they're dying around age 60, around age 70. So they're not reaching age 80. So this looks like, health disparities are decreasing, but what's actually happening is that the sickest folks are dying before they get to age 80. So only the folks who with the least number of chronic conditions who are the healthiest are left at age 80, to be compared to white Americans who have generally had the privilege of less chronic conditions across the life course and therefore have lived longer lives. So again, I know this is a bit of a kind of weird thing to think about, but essentially what this means is that this kind of, eventual decline in disparities with white folks and Black folks looking similar by age 80 is just because Black folks are experiencing greater rates of mortality at younger ages. So it is not that health disparities are going away. It is actually that health disparities are so bad that we have such differences in life expectancy that the Black folks left at age 80 are the most, healthy, the least vulnerable to chronic conditions. And that is a really upsetting fact, right? That folks are literally dying so much sooner than white folks that it looks like health disparities are declining when they're really not. And again, it's important for us to think about this, because if we just thought that health disparities were going away at age 80, we might not feel, and by we, I mean, policymakers, practitioners, might not feel like we need to do anything, when in fact there is lots of things that we should do so that we don't have folks dying at such young ages compared to white folks. Now I want to give you an example of how dangerous it is to not consider selective mortality using the case of COVID-19 mortality. And this, if after this lecture, maybe you'll go look at some news articles, because this was actually something that came up quite a bit when we started to think about racial disparities in COVID-19 mortality. Some folks did make conclusions like this without thinking about this process of selective mortality. So here on the left, I have COVID-19 mortality rates, and these are called crude death rates. How these are calculated is simply the number of people in a certain racial category who have died divided by the number of people in that racial category in the United States, times 100,000. So it's per 100,000 folks. So if we just look at crude death rates, we do see that Indigenous people are dying at a much higher rate than other groups. But interestingly, it looks like whites are dying at about the same rate as Pacific Islanders and Blacks, right? People who are Black, Pacific Islander, white, or Latino look to be kind of comparable, with Latino being slightly lower. And again, what these rates are suggesting is that there are about 330 whites Americans dying per 100,000 white Americans in the whites in the United States. and about 340, 350 Black and Pacific Islanders dying per 100,000 Black and Pacific Islanders in the United States. So if I were just to look at this, right, so these are just crude death rates. This is not considering at all the process of selective mortality. I would look at this and I would say, oh, there's not really that bad of racial disparities. I mean, we need to be concerned about Indigenous racial disparities for sure, but I mean, Latino is lower than white, right? You know, if I'm just sort of naively looking at this, I'm going to say, oh, you know, COVID-19 is, you know, a colorblind disease, which is actually a news article title that had come out during this time. But we all know that that is not the case. Racial disparities absolutely do exist, and they are very important to consider. Because when we take into account selective mortality, racial health disparities look quite stark. So these on the right are called age-adjusted rates. And what age-adjusted rates do is they take into account the number of older folks in each sort of racial category. So white Americans generally live older because of racial inequity, because of racism as a fundamental cause of disease. So there are going to be more older white Americans compared to older Black Americans, older Pacific Islander Americans. And we know that COVID-19 has disproportionately affected older Americans, right? So if you get COVID-19, you're much more likely to die if you are 65 years or older. This has kind of been the standard of CDC recommendations, right? For boosters and all that kind of stuff. So proportionately, there are more older white Americans who are at risk of higher mortality compared to the proportion of older Black Americans or older Pacific Islander Americans. Again, because racism has led to these populations dying at younger ages than white Americans. So when we consider this process of selective mortality and we take into account the different ages in the population, we see that there are very, very stark health disparities. So now it very much looks like, even though, for example, Latino death rates looked lower than white death rates, they are actually much higher. And this is the same case for Pacific Islander and Black death rates compared to white death rates. So again, if we had just looked at crude death rates, somebody might conclude that there are no racial health disparities in COVID-19. It is just the racial health disparities between Indigenous folks and white and Asian folks that we need to focus on. When in fact, there are racial health disparities across the board for Indigenous, Pacific Islander, Black, and Latino folks compared to white folks, with around 466 Pacific Islanders per 100,000 dying from COVID-19 compared to 267 white Americans per 100,000 dying of COVID-19. So this I just again wanted to show you because I think this is a really stark way to see how important it is to consider selective mortality when we're making conclusions about health disparities so that we don't underestimate health disparities in the United States, because we need to have accurate estimations of these health disparities if we want to communicate to those in power how important it is to develop interventions. So the key takeaways from today that I want you all to kind of think about and mull over. I know this was a lot of information. I'm excited for us to be able to dive into some discussion later. But the key takeaways here are that health outcomes are patterned by systems of inequality that advantage some and disadvantage others. Disparities are driven by unequal access and exposure to risks and resources. Differential access is apparent across the life course, leading to an accumulation of risks and resources. Again, that cumulative inequality bit. Psychosocial resources can buffer the impact of social conditions on health. We have human agency in the face of systems of inequality, but again, that's not something we should hang our hat on as our main intervention strategy. And finally, health inequalities may be obscured or underestimated if we do not consider life course processes. So you might be thinking, where do we go from here? What do we do, right? Again, these are really stark and upsetting health disparities. So what are we supposed to do? Well, I've got two videos here for you all. I'm going to stop sharing my slides for a second so that I can get these videos set up. And I want you all to watch these videos, and I want you to think about how these organizations address health disparities. So what their plan is for health disparities. One is coming from the American Association for Public Health, and the other one is coming directly from Healthy People 2030, which is a government run program. And I want you to think about how they're addressing health disparities and how that may or may not sort of go with a lot of what we've talked about today. And I hope that we can talk more about these later, and they're really short clips. They're both about 3 minutes. Okay, so this is the first clip.
Hi, I'm Mighty Fines. I'm an
Pausing it, can you all hear that, the sound for that? Maybe give me a thumbs up if you.
With the American Public Health Association, and today we're going to talk about health equity. Let's imagine that you're a baseball fan on your way to a game. But when you reach the stadium, there's a wooden fence blocking the view. Some people are standing on milk crates to catch a glimpse. Some are tall enough to not even need a crate, but they're standing on a whole stack of them anyway. And some are standing in a ditch where even a crate couldn't help them. So some get to see the game and some don't. We face a similar situation in public health. There are people who can easily access whatever resources and services they need, and others who struggle to get the basics, like healthcare, clean water, safe housing, education, and a livable wage, which means that certain groups of people are more at risk for disease, but have less ability to get treatment. So they may be more likely to get severely sick or die from treatable and even preventable diseases. Let's go back to our baseball example to explain more. Just like a difference in height helps some people see the game, many health outcomes are a result of things we can't change, like age or genetics. Bones become more brittle as we age, so we'd expect 80-year-olds as a group to suffer more hip fractures than 30-somethings. On the other hand, back at the game, some people weren't naturally tall enough to see and didn't have any crates, and others were forced to stand in a ditch. Likewise, many gaps in health trends are caused by lack of access to various resources and are rooted in unfairness. A person's education, income, employment status, and housing all have an impact on their health. These are what we call the social determinants of health. And when non-medical factors like these contribute to a difference in health, we call that difference a health disparity. Like Black mothers are almost 3 times more likely to die in childbirth than white mothers, and are less likely to have access to quality prenatal care. There's no biological reason for this, but there is a strong history of medical racism towards Black women. So this is an example of racial inequity, or the unfair and unequal distribution of resources along racial lines. When addressing health disparities, some focus on equality, which would mean giving the same assistance to all. But this doesn't often work in practice because some people need more support or a different kind of support than others. An online portal that lets you quickly sign up for vaccinations is a great idea, but for people who don't have internet access or a car to get to the vaccine clinic, it's still a one-size-doesn't-fit-all solution. That's why public health professionals are focusing on equity. An equity approach strives to give everyone the chance to live their healthiest possible life, but gives extra attention to those who face ill health because of a lack of access or opportunities. Like the more than 2 million people in the US who don't have access to running water or plumbing. Some of these folks have no choice but to get water through old, poorly maintained pipes, which can lead to serious infections. And the people affected by poor water quality are disproportionately communities of color, children, older adults, and low-income or rural communities. Historically, less affluent neighborhoods haven't received enough funding to fix their water infrastructure. To make sure this problem is handled equitably, APHA recommends that federal and local governments use any extra money to improve the water infrastructure in those neighborhoods. APHA also recommends that governments, schools, hospitals, and other branches of public service work together to identify and provide the specific support the communities need, so everyone can live their healthiest possible life. So that's health equity in a nutshell. A public health approach that tackles health differences which are avoidable, unnecessary, and unjust, and works to improve everyone's health. Thanks for watching. This video is a part of a series created by.
Okay, so before we get to the next video, I just want to recap the really important thing there, again, to think about interventions, is the difference between equality and equity in interventions. So equality meaning that we're going to intervene the same way for everybody, whereas equity meaning that we want to give everybody the same equal access to a healthy lifestyle, which may mean that some folks are going to get more help than others. So I want you to continue to think about that. And I'm now going to show us Healthy People 2030. And I want you all to now think about this. Again, Healthy People 2030 comes directly from our government. So this is something that is our government's goal of creating healthy life for Americans by 2030. And so this is how they believe they are going to address social determinants of health. So I want you to watch this and think about maybe how this might be similar or not similar to the video you just saw.
HHS, we define the social determinants of health as the conditions in the environments where people are born, live, learn, work, play, worship, and age. Social determinants affect our health, well-being, and contribute to health disparities and inequities as well. Healthy People, our nation's longest-running disease prevention and health promotion initiative, emphasizes addressing the social determinants of health to create environments that promote health and well-being for all. I'm Admiral Rachel Levine, Assistant Secretary for Health at the United States Department of Health and Human Services. Healthy People 2030 provides a framework for thinking about the social determinants of health across 5 domains. Here are the 5 social determinants of health. First, economic stability. People with steady employment are less likely to live in poverty and more likely to be healthy. By helping people earn steady incomes, we can achieve economic stability for all. Second, education, access, and quality. People with higher levels of education are more likely to be healthier and live longer. By helping students excel in school, we can improve educational access and quality. Third, healthcare access and quality. Many people in the United States are unable to get the healthcare services that they need. Increasing access to high quality healthcare services will ensure more individuals can attain their full potential for health and well-being. Fourth, neighborhood and built environment. Health and safety risks like high rates of violence and unsafe air or water impact health and quality of life. By creating safe communities, we can provide opportunities to promote playing and physical activity. And fifth, social and community context. Increasing relationships and interactions with family, friends, neighbors, and community members is beneficial to an individual's health and well-being. To learn more and see how others are working to address the social determinants of health across the nation, please visit healthypeople.gov.
Okay, so again, that came from the American Public Health Association and then Healthy People 2030. And I hope kind of what you were able to take away from there is that there is a little bit of a different vibe when we're thinking about the video that you saw from American Public Health Association has really thought about sort of these fundamental causes of disease a bit more than I feel like that Healthy People 2030 video did. So the Healthy People 2030 video was still great, right? These are great things to strive for. But something that I found was lacking in that video, and maybe we can talk a little bit more about this, was that acknowledgement of how people are coming to the table in different ways, and that there might be some of these issues with a one-size-fits-all approach to intervening on folks' health. Okay, so what's next? I kind of provided you all with some questions, but just to recap, these are some questions that I hope can guide our discussion later. I want you to think about that outside of those discussed today, can you think of any other fundamental causes of disease? I want you to think about some policies that could address fundamental causes of disease. You know, this can be any of them that we've talked about or any that you come up with. And how might health practitioners address fundamental causes of disease? So some of you all might be pre-meds, you might be coming or interested in nursing or PA school, and so you might be becoming health practitioners. What do you think health practitioners can do to address these fundamental causes of disease? Another question is, when in the life course should we intervene on unequal risks and resources? This is a very difficult question and not one that has kind of a straightforward answer. So I'm super interested to hear what you all think. How might ignoring life course experiences, thinking about life course health, how might that shape conclusions on health disparities if we ignore where people are coming to the table? And finally, can you think of an example when selective mortality was not considered in the discussion of health disparities and any kind of ramifications that may have for health disparities and health disparities research? And with that, I'm going to stop sharing and open up for discussion. That is all I have for you all today.
So
Thank you so much. That was amazing.
fabulous. We thought maybe if you wanted to look at some of the questions